Good afternoon, everyone. So I'm going to talk to you all about a project that we've been working on out of Montefiore with a great team of folks from pediatrics, family medicine, social work, medical educators, and psychometricians. So we're looking at the development and validation of a performance-based assessment for communication about social needs with patients that we've called Go Deep. So I wanted to just acknowledge some of the funding that has gone into this project: the American Medical Association, the Stemler Foundation, and the Empire Clinical Research Program. So as a background, many of you all know that unmet social needs have a great impact on health outcomes, and also that screening for and addressing social needs has the promise to improve patient-level outcomes. And so many of us have been working in this space, and that social needs screening is also now part of regulatory guidelines. So it's happening in a lot of places. However, what hasn't been emphasized as much is how do we communicate with patients about social needs? And so in recognition that clinician training on communication about social needs is critical to the success of these efforts, we decided to delve deeper into this. So our aim was to develop a stakeholder-informed, multidisciplinary communications checklist for social needs conversations with patients that had some validity evidence. So this is the process that we undertook. We started out with an interdisciplinary working group. We conducted a literature review, and from that developed checklist items, and with it sample scripts and a behavioral assessment scale. And then we recruited some national experts, some of whom are in this room, so thank you. And we also did several focus groups with stakeholders. So we interviewed clinicians, we interviewed patients, and we also interviewed community health workers. And then we went back to our national experts and got some feedback, and we're now about to embark on the piloting stage. So that's where we are. So our plan is to pilot with resident physicians, starting in internal medicine, get some cognitive interviews, some feedback from our faculty raters, our residents, and then look at things like score reliability, dimensionality, setting competency standards, and also criterion validity. So implementing a curriculum and seeing, does our assessment, is it able to predict improvement or change after that? Okay. Our interdisciplinary working group had the members that I mentioned. We also looked at some theoretical frameworks. So trauma-informed care was important, strengths-based approach was important, relationship-centered care, and also motivational interviewing techniques. We started out looking at some existing communication skills frameworks, but realized that these frameworks needed to be adapted to social needs conversations specifically. So this is the model that we're working with now. It's called Go Deep. So give explanation for screening, and in that, offer choice. Then the next section is delve into social needs, exhibit empathy, explore patients' perspectives, and partner to develop a plan. So for each item in this domain, we have a list of behaviors that we're assessing. So as I mentioned, we embarked on some focus groups. Each focus group had about 5 to 6 participants. We did it with interdisciplinary resident physicians, community health workers, and patients and community members. And in our focus groups, we were looking at, well, what are some effective or helpful strategies for communicating around social needs? What are some challenges? And then we asked for feedback on the domains that were developed from the literature. And so we took detailed notes. We did like Zoom-assisted transcription. One of our patient focus groups was conducted in Spanish. And then we used rapid qualitative analysis of the transcripts to come up with some themes. And this involved matrix development, true raters, and adjudication. So we had a lot of data. This is not all the data. This is just some of the data that I wanted to highlight for you all about some successful strategies that folks came up with. So patients wanted us, or wanted clinicians to ask about and explain social needs. So why are we screening for social needs? They felt that was important. They definitely wanted an empathic approach, and that included tone and nonverbal cues as well. They wanted their providers to recognize them and show interest in them as patients. And this was like something that was very prominent. They were like, recognize me as a human being, know my name, stop looking at the computer, stop rushing the visit, take what I say at face value. So that was something that was really, really important to them and fundamental. And they did want resources for social needs. They were like, if you're asking me these questions, do offer resources. And in some of the focus groups, folks even were interested in resources up front without screening. And so these are some of the quotes from the patients. So I want my doctor to use my name and refer to specific details about me and my life, which shows a doctor is paying attention, adapts advice or care recommendations to the circumstances I'm going through. I want them to demonstrate empathy by validating the patient's feelings, even if it means acknowledging patient's emotions, even if you can't do anything about them right away. I'm telling everybody, but nobody's doing nothing. So I think people want to see some kind of action too. We also asked our clinicians, which included resident physicians and community health workers. Folks resoundingly believed that social needs screening was part of healthcare delivery, and they liked the universal aspect of social needs screening because it opened the conversation with patients. They wanted to have deeper connections with community health workers, the resources that were available locally. Normalizing, acknowledging, validating were all communication skills that resonated with them. Expectation setting was important, and a lot of the resident physicians wanted to know, what could a patient expect resource-wise, and how do I set that expectation with patients? And then hands-on teaching and practice was really important as well. These are some of the quotes from our resident trainees. So asking permission and normalizing things are great starting points for screening. I would be partial to having them meet up with a community health worker or social worker right then and there. And this is also something that came up in several of the focus groups. I think you should elicit how they feel about it at the end. Does that sound good? And so this was actually an additional item that we ended up adding. So we asked 9 national experts, so topic leaders, folks who had published in this area, about what they thought about the domains and behavioral skills. And by and large, there was generally great agreement that they were clear, the domains were complete, they were relevant, and there was no overlap. There was a lot of comments about the sample script and also the behavioral scales that we ended up using. These are 3 comments that I wanted to highlight from our experts about the general behavioral items that we chose. So one of them was that referral to resources may not be the only appropriate response to social needs. So in our initial version of this checklist, we had in the partner to develop a plan section, referral to resources as like the thing to do. And then folks were like, no, you should think about other interventions that are also appropriate. And so we ended up adding an item, assess whether a clinician accommodates treatment plan to social circumstances. There was a lot of controversy in our focus groups about the behavioral item, illicit impact of social needs on health. And this was part of the delve into social needs section. And so some folks believed, like our patients actually, were saying, well, if you're gonna screen me about it, it should be related to health, And then other folks, like our residents, were like, well, how much does this really change management to have an explicit conversation about the linkage of social needs to health? We actually, when we asked our experts, they were split, 50-50. A lot of the experts said, well, I've noticed in my practice that actually making this link very clear was helpful. So we ended up keeping this item for piloting purposes, and we'll see what happens. And then lastly, clinicians felt that it was important to summarize or wrap up the visit with patients, and so that item was added. Okay, so this is the actual behavioral items that are part of the domains. So give explanation for screening, starts with discuss why screening is important, normalize screening of social needs, establish confidentiality, and offer choice. In the delve into social needs, we have ask permission to discuss social needs, prioritize social needs to focus on, ask what matters most, ask about social needs using open-ended questions to start, elicit impact of social needs on health, explicitly acknowledge or complement sharing of experiences, and reframe social needs in structural terms. And then the exhibit empathy section came from a pre-existing model called the SAVE model. So we kind of took that model verbatim, which was emotion identification, acknowledge emotional impact of social needs, validate emotional response, provide support and partnership, and convey empathy through nonverbal behaviors. And then our last two domains were explore patients' perspectives, which was elicit and acknowledge prior experiences with resources, elicit and acknowledge strengths, inquire and help set expectations for addressing needs, and then partner to develop a plan was elicit individuals' input in developing a plan, advise on available resources, assist in accessing resources, accommodate treatment plan to social circumstances, be transparent about information sharing, wrap up in a patient-centered manner, and ensure follow-up. Okay, so each of these behavioral items then also has a scale. So this is an example of one of the items, discuss why screening is important, and the scales generally are did not do, partially did, and completely did. So you can see how that looks like for this particular item. And then we also, for each of the items, develop some sample scripts to help guide in training using this checklist. So this is an example of the explain that item, discuss why screening is important. So this was a sample script that we had there. All right, so we're now in the process of preparing for piloting this checklist. So we've developed 2 standardized patient scenarios, and we're gonna have our resident physicians experience the standardized patient clinical scenario, and we're gonna use this checklist as an assessment tool to see how the tool performs. So we're going to have faculty members use the assessment tool as an observation while the residents are going through the encounter with the standardized patient. We're going to also have a second faculty member in the room for inter-rater reliability. And we're actually having the SPs do like a shorter version of this checklist to see what their feedback is going to be, and that's going to include the empathy domain, and then they're going to be randomized to complete one other domain. And then we're also looking at curriculum implementation, so trauma-informed social needs communication using role play, and seeing if that has an impact on how they perform. In conclusion, we use some guiding frameworks like trauma-informed care, relationship-centered care, strengths-based approach, and motivational interviewing. We have pretty good content validity evidence for this checklist, but we're going to be piloting to determine if it's reliable, if there's criterion validity, and also we're looking into potentially piloting this with other health professional cohorts, as we know that these conversations don't just happen with physicians, but other folks on the team as well.